Hello my geniuses, welcome to another pharmacology lecture series. Today is a great science tutor Lorenzo, and today we'll be talking about the oxytocic and tocolytic medication. Again, always remember oxytocic and tocolytic medication. These are medications which act on the uterus. In our last video we talked about the ergot alkaloids, and part of the ergot alkaloids works on the uterus too. So today we are just taking on the oxytocic and tocolytic medication. So make sure do well to stay to the end of this video, because I'll be giving you important exam questions that will be coming out for your exam. So stay to the end. I'm summarizing, I'm explaining, I'm giving you the connections so that when you want to answer them in your exams, it will be much more easier, and you will use this connection when you want to diagnose and treat a patient. So stick to the end of this video. Like, subscribe, and share to your classmate or anybody that needs the video solely. So let's jump right into the video. So remember, today we are doing oxytocic and tocolytic medication, which are drugs that act on the uterus. You get it now? So again, oxytocic and tocolytic medication, drugs that act on the uterus. So they are just what's an opposite: oxytocic, tocolytic, which is oxytocic is an agonist, while tocolytic is an antagonist. Again, oxytocic is an agonist which acts on the uterus to provide contraction, while tocolytic counters the oxytocic and does what? Inhibition. So if oxytocic is doing contraction of the uterus, I get it now, tocolytic is preventing it. So doing contraction of the uterus, you can use it for so many things. So contraction of the uterus can be used to induce labor. You get it now? So a patient is maybe 38 weeks pregnant or close to delivery, I get him now, and maybe delivery is hard, or maybe he or she cannot, she especially cannot push the baby. What happens? So you give them an oxytocic medication to induce labor. Or a patient is having a postpartum bleeding or hemorrhage, and you want to inhibit it, you also use an oxytocic too. But a tocolytic medication is used to prevent labor. You don't want labor. Maybe the pregnancy is 7 weeks or 6 weeks, and there is induction, and you don't want it. What happens? You prevent it using tocolytic medication. I get it now. So you don't want to allow the baby stay there for a long time, not to come out preterm. So you use a tocolytic medication. So oxytocic induce, tocolytic inhibit. I get it. And you are choosing the drug based on the clinical situation happening at that point in time. So important. So you are not just using them or studying them. You are using them because you'll be faced with this kind of situation when you are practicing medicine. I get it now. Practicing any part of your field you want, so you always need it. So now, all you have to important now is to classify. How can we classify the oxytocic and tocolytic medication? So now, the oxytocic medication can be divided into what? One, you have the oxytocin analogs. You have the ergot alkaloids, and you have the prostaglandin analogs. So oxytocin analogs, ergot alkaloids, and prostaglandin analogs. Again, why tocolytic medication? You can classify them under what? Calcium channel blocker, which is non-dihydropyridine. Which is dihydropyridine. You get it now. While you have the beta-2 adrenergic agonist. Again, then you have the magnesium salt. Then you have the prostaglandin synthesis inhibitors, which is NSAID. So NSAID does what? Inhibit prostaglandin. And you have the oxytocin receptor antagonist. So now, easy, very, very important. So under oxytocin analogs, you have the oxytocin and carbatosin. You get now, oxytocin and carbatosin, don't forget. Under ergot alkaloids, you have the ergometrin and methylergometrin, or you can call ergometrin ergonovin, don't forget. Under prostaglandin analogs, you have the misoprostol, which is PGE1 analogs. You have the dinopostone, which is PGE2. Are you getting now? And you have the carbapost, which is PGF2 alpha. These are analogs of prostaglandin. So under tocolytic, you have the calcium channel blocker, which is dihydropyridine, which is nifedipine. You have the beta-2 adrenergic agonist, which is terbutaline. Then you have the magnesium salt, which is magnesium sulfate. You have the indomethacin, which is an NSAID. And you have atosibam, which is the oxytocin receptor antagonist. So very, very important. So if you are talking about the summary of their structures, everybody have their own structures. Remember, Ergot Alkaloids has a ergoline ring, which is an indoor fused with a tetracyclic ring. They are fused together, and which you augment the ring in order to get a therapeutic use you want. I get him now. And you see, oxytocin directly is different because oxytocin is released directly from the hypothalamus. So it's a neuropeptide, which is about 9 amino acids, which is fused together. Then you have prostaglandins from arachidonic acid. Again, every drugs have their own chemical constituent. So you bring in the first one, which is oxytocin. Don't forget, oxytocin is a urotonic drugs. You get it now. So oxytocin. So this is a natural. So you can use the word Pitocin because Pitocin is a drug which acts as oxytocin. You get it now. So oxytocin, you know it as a pituitary hormone. You get it now because it's derived from what they call the hypothalamus, the paraventricular nucleus of the hypothalamus. So when it's derived from the paraventricular nucleus of the hypothalamus, it uses the hypothalamus-hypophyseal tract to be stored inside the posterior pituitary gland. So it's produced from the hypothalamus and it rests or it stores in the posterior pituitary gland till you need them. Yeah, so during love and affection, because women, during love and affection, oxytocin level increases. When a mother loves her baby, oxytocin is released. During birth, maybe when a mother wants to breastfeed the baby, oxytocin is released. So oxytocin is called the love hormone. And when oxytocin is released, what happens? It binds to the oxytocin receptor. Especially for this one, it binds to oxytocin receptor in the uterus. And when it binds to the oxytocin receptor in the uterus, it activates phospholipase A2 to give us PIP2. So when phospholipase A2 enzymes act immediately after oxytocin binds to its receptor, it forms what we call PIP2. So PIP2 really forms IP3 and DHG, which releases calcium, and calcium is needed for uterine muscle contraction. So you are when you release oxytocin, you are contracting the uterine muscle. Again, very, very important. So it's not taken orally; it's taken parenterally, which is IV and IM. I get it now. And they are metabolized in the liver by the oxytonase enzymes. So the oxytonase enzyme break down or metabolize oxytocin, and it can be released by the kidney. I get it now. It can also pass through the placenta. But remember, medically, in the hospital, it's called Pitocin. So Pitocin is just the drug form of oxytocin. You get it now. So the half-life is about 3 to 5 minutes, and it stays up to 10 to 15 minutes. So it doesn't have a long duration of action. It's just less than 15 minutes. You get it now. So what is it used for? It's used to induce labor, Pitocin. So when the woman is giving birth, maybe there's no strength, the pelvic floor muscles are not firing very well, they are not contracting very well, so they give the woman Pitocin. So what does oxytocin or Pitocin do? They induce labor by causing contractions. They also augment labor. Augment labor is that they just as the woman is also pushing, it's also used to help the woman too. So please prevent postpartum hemorrhage, which I have said already, by contracting the arteries, the uterine arteries, they are decreasing bleeding because after CS, sometimes there can be internal bleeding. So the use of oxytocin helps to vasoconstrict the muscle, which clamps on the uterine blood vessel, decreasing blood loss. Treatment of postpartum hemorrhage, which you have talked about, and also facilitate expansion of the placenta. Remember, immediately after the child has come outside, first one, there are 3 stages of labor, which is the descent of the baby, which is the removal or the parturition of the baby, like baby coming outside from the vaginal wall, and the last one is the elimination of the placenta. So it also helps in the elimination of the placenta. Again, so side effect here is that when you are doing it too much, you overstimulate the uterine muscle, which is the myometrium, you overstimulate it. So in doing that too, there can be uterine rupture, which is also rare, because when you overstimulate it, there could be micro tears there. Also, there could be water intoxication and hyponatremia. Why? because when there's hyponatremia in the sense of at high dose or prolonged use of oxytocin, what happens? Your sodium level decreases, because when sodium level high, there's depolarization, and depolarization increase calcium entrance, which causes contraction. So there could be hyponatremia. Why? Because your sodium level have dropped due to the action of excessive sodium. Sodium might be used for depolarization of the smooth muscle, which helps in calcium also. So there's water intoxication too. There's hypertension. Why? Why is there hypertension? In the sense of it's just like a rebound hypertension. Just like a rebound hypertension. So naturally there's nausea and vomiting, which is due to irritation. So hope you have gotten it. And contraindications, when should you need to use it? First of all, when there's a cephalopelvic disapprobation, remember, due to the disapprobation of the fetus, when the fetus is descending. One, obstructed labor, don't give oxytocin. When there's obstructed labor, you have to go in for CS. So when there is bleeding during birth, you just have to not use it, because why? You just force the woman. There will be prolonged stay of the fetus inside the birth canal, and staying there for a long time is very bad. Also, when there's previous uterine scar, if there's previous uterine scar or uterine rupture, you don't have to use it because it prolongs TM the more. You get it now? Placenta previa, when the placenta is wedging the cervical, when it's blocking the cervix. Because sometimes, remember, the baby's head is close to the cervix, and which lead the baby outside the womb. But if the placenta is blocking the cervix, you get him now, that is called placenta previa, which is much more consistent and bleeding excessively. So when there's placenta previa, you don't need to give oxytocin. So there's no natural delivery, it has to be on CS. When there's severe fetal distress, so when there's severe fetal distress, maybe due to the misappropriation and the baby cannot descend very well, then you start giving oxytocin, inducing the mother excessively, which increase fetal issue also, because fetal distress can complicate the respiratory flow, can complicate the blood flow, and can damage the baby, causing issue. Hypersensitivity of the jaw can also be seen too. You get it now? So that is it. Also, drug interaction, don't pair with other euthyroid drugs and also prostaglandin, and there may be increased hypertension effect when you use anesthetic drugs, so don't pair. They are just reactions too. So ergot alkaloids is the next one. So we have talked about ergot alkaloids in my last video, and remember, ergometrin, methylergometrin, I get him now. So ergometrin stays at least less than 2 hours. Methylergometrin stays for about 3 to 4 hours. So methylergometrin lasts more longer, for longer use. So another name for ergometrin is ergonovin, and they are used to also stimulate the smooth muscle of the uterus. Don't forget, they are used to stimulate the smooth muscle of the uterus. Don't forget, it's very, very important. You get it now? So what do they do now? They bind to alpha-1 receptor. So alpha-1 receptor on the smooth muscle of the uterus. So what does it do? If it binds there, so first of all, it binds to adrenergic receptor, alpha-1 adrenergic receptor, and also serotonin. So if you bind to alpha-1 adrenergic receptor and serotonin, are you getting now? What happens? You are vasoconstricting the uterine blood vessel, and also causing contraction of the uterine smooth muscle. Yes, so how do you do this? You do this through the second messenger pathway, PIP2, IP3, DAG, calcium. This is how you do this. Again, so we have talked about it. So what is you using? Specifically, when you use ergot alkaloids, you are timing what you call and management of postpartum hemorrhage. So you want to treat it and you want to prevent it. You get it now. You don't use ergot alkaloids for induction of labor. Why? Because when it gets increased, when you use it, there's a risk of ergotism. So you don't use it for patients like that. You get it now? So one thing you have to know, absorption is absorbed orally, which we talked about in the last video. But some patients can be given parenterally, which is IM and IV. It can be metabolized by the liver. And remember, ergometry stay for less than 120 minutes, which is 2 hours. While the methylergometry stays for at least 4 hours. You get it now? So the duration of between maybe 2 to 4 hours or 3 to 6 hours, and they can be eliminated from the bile and urine. You get it now? So also side effects. When you vasoconstrict the blood vessel, there's a risk of what? Hypertension. So don't even give it to patients with that. There's nausea and vomiting naturally because there could be irritation. The drug could inflame the body and cause irritation. Are you getting now? So also it could cause headache, but like rebound headache. So a rebound headache to increase in ICP. Are you getting now? Intracranial pressure, causing what? Headache. Dizziness due to decrease in cranial blood flow. You get him now. So when there's decrease in cranial blood flow to the brain tissue starts decreasing itself by protecting itself through Cushing reflex in dizziness. Peripheral vasoconstriction, which decrease blood flow to the periphery due to increase in peripheral resistance. This can be seen causing cold extremities because the blood is not present to lose heat. So there could be chest pain, which is rare. Why is there rare? Because ergometrin is usually for specific to the uterus. Okay, now that is why it can really cause chest pain. It can really cause myocardial infarctions and co. So don't give it to a patient that is pregnant. Why? Because it could induce labor. Don't give it to a hypertensive patient because it's already reducing peripheral resistance. So don't just add to the patient problem. Don't give it to a preeclampsia patient because it's already hypertensive, and when you give it more, what happens? It even shorts the blood vessel, causing ischemia to the baby. The baby might die, and also it could risk the mother. Don't give it to a patient with eclampsia, which is already seizure prone, because it could increase more of the ICP pressure, causing stroke, and the patient might die. Severe hepatic or renal disease because of prevention by reducing blood flow to the liver and kidney. Also, peripheral vascular disease, which decrease blood flow to the periphery, preventing risk of gangrenes or any tissue death. Hypersensitivity also, which you also know. So drug reaction, don't add too many or give ergotamine or methylergotamine with other vasoconstrictive medication like sympathomimetics like phenylephrine, pseudoephedrine, ephedrine. All those drugs, don't give them alongside because it can short the blood vessel well. Now, when you give oxytocic drugs like Ergot Alkaloids, what happens? It may reduce the effect of antihypertensive medication. Yeah, now. So when you are treating a patient with antihypertensive and you are giving them ergometrin, what happens? It will not work. The antihypertensive which you are using to prevent hypertension will not even work. Also, are you getting now? So when you also give Ergot Alkaloids with CYP3A4 inhibitors like macrolides, like azoles, like protease inhibitors, what happens? It will not even work. Are you getting that? They will increase, causing high toxicity of the ergot alkaloids, causing ergotism. So the next one is what? Prostaglandin analogs. We have talked about the first one, which is what? Oxytocin. We have talked about the ergot alkaloids. So we are talking about prostaglandin analog. Yeah. So there are three classes here. We have PGE1. I get the analogs, which is misoprostol. We have PGE2, which is dinopostone, and we have carbapost, which is PGF2 alpha. So what do? You always the same thing they used to do, like prostaglandin. Prostaglandin is gotten from arachidonic acid, so it's simple. Arachidonic acid. So when it's coming, what does it do? It binds to the same receptor, which is the prostaglandin receptor. So when it binds, what happens? The same thing, PIP2 to phospholipase A2, getting IP3 and DAG, which is second messenger pathway, then bring calcium. If we bring calcium, what will calcium do for us? Calcium increase contraction. But which contraction? Uterine muscle contraction. So when there's uterine muscle contraction, there will be ripening of the cervix. Now, because during birth, if the cervix have not dilated to about 10 centimeter, baby cannot come outside. So it needs to be dilated to 10 centimeters so that there could be descent of the baby. Okay, now so what we have, which is misoprostol, they use it for always to bring out the baby, maybe emergency uterine contraction, maybe you want to give birth to the baby preterm, or maybe you just want to push the baby out, they give the person misoprostol. Are you getting now? Or maybe you want to abort or anything, so give the misoprostol, dinopostone, and carbapost. These are basic three drugs you give a patient when you want to achieve any of this aim. You get it now? So the next one is the pharmacokinetics. Now in the pharmacokinetics, The next one is the pharmacokinetics. So what is the pharmacokinetics of all of them? One thing, we will still do prostaglandin analogs on their own. You get it now? We still do them on their own. But one thing you have to know that the mode of taking, the way they take the drugs, how they take it and how they absorb it is different. Some drugs you take them orally, some drugs you insert them to the vagina, some drugs you take them sublingually. Okay, now some drugs you put it to recti, to depository. Some drugs you put different way of giving the drugs. So now second one, it could be absorbed and it could be metabolized in the lungs, in the liver, and in the kidney. So half-life is also short, between 20 to 60 minutes, but it can last because they have high plasma binding. So they bind to plasma protein, which retains them in the blood rather, for a long time. So they have a duration of about 2 to 6 hours. You get them now, and they are always excreted to the renal system. So just like oxytocin, or we call Pitocin, when you give a patient these same prostaglandin analogs, what happen? The same thing. It induces labor like oxytocin. Then it also causes cervical ripening, so it can be dilated so that the baby can be given birth to. Termination of pregnancy, especially the first trimester. So you use more of a misoprostol because dinoprostone is more used in postpartum hemorrhage. Treatment of postpartum hemorrhage. So you can also use misoprostol there also. So misoprostol will be used for also to treatment of postpartum hemorrhage and also termination of pregnancy too. Medical management of missed or incomplete abortion, misoprostol too. So all these things are very, very important. We'll still do them separately, yeah. But we are just trying to know. So you see, oxytocin and prostaglandin analogs, they do one work, and the work is induce labor, but only prostaglandin analogs do cervical ripening. Also, both of them do treatment of postpartum hemorrhage together with Ergot Alkaloids. Get it now? The side effects now. The side effect is still simple, the same thing, fevers and chills. Why? Because the presence of prostaglandin. So prostaglandin is also released during inflammation too. Okay, now, so when you want prostaglandin to come more, what are you doing? You are inducing inflammation in the patient. So what happens? So this first sign of inflammation is fever. So there will be fever, chills, because what does prostaglandin do? PGI2. So 2-PGI2, prostaglandin, which is prostacyclin now, what does it do? It will vasodilate the blood vessel, causes blood vessel permeability. So 2-PGI2. So you can see fevers and chills because they send information to the hypothalamus to reduce the hypothalamic set point. So that's why when you are giving a patient prostaglandin, you should know about the fevers and chills because prostaglandin is also released during as a inflammatory metabolites too. Are you getting that? And this can cause blood capillary permeability. Yeah. So fevers and chills is the first one. Nausea, vomiting, and diarrhea. So naturally there will be irritation of the chemotrigger zone of the brain, which is the vomiting center, which could induce emesis, which is vomiting. So there could be diarrhea because are you getting me? So what does it do at this particular point? There'll be increase in motility and secretion. Why? Because at this particular point, to the smooth muscle, PGI2, what does it do to the smooth muscle? It vasoconstrict it contract the smooth muscle, then reduce the blood. It contracts the smooth muscle and drops the blood pressure. So that's what it do. So prostaglandin can also equally cause smooth muscle contraction, which you could see in diarrhea because there will be increase in peristalsis. So when there's increase in peristalsis to the smooth muscle, what do they now do to the smooth muscle? They cause peristalsis movement, increase in GIT motility secretion, but the blood vessel, they drop the blood vessel. Okay, so there's a risk of that. 2-PGI2. Vasodilating the blood vessel, causing fevers and chills. Also contracting the smooth muscle of the GIT, increasing peristalsis, which you can see as diarrhea. They cause abdominal cramps. Yes, they cause abdominal cramps because when there is nausea, vomiting, and there's diarrhea, excessive movement of food with less contact time, which is diarrhea, what happens? There will be pain. Are you getting? Because food is not staying. And you start getting tired. Why do you get tired? You get tired because your food has less contact time, there's no absorption, so there's no nutrients, your energy level drops, you start feeling dizzy, fatigued, Are you getting me now? So also uterine stimulation or hyperstimulation, whereby, remember, prostaglandin works on the uterus, inducing labor. So overstimulation will cause tiredness. So the uterine muscle, the pelvic floor muscle, will be affected, which will lead to urinary incontinence and co. Bronchospasm, especially with cavapos. Remember, bronchospasm is another thing. What do they do? Remember, prostaglandin to the bronchus causes what? Constriction. Anytime you release an inflammatory metabolite, what does it do to the blood vessel? It vasodilates the blood vessel, increasing capillary permeability. It contracts the smooth muscle of the body, especially the GIT, increasing diarrhea, even of the body, doing so many things of the uterus, causing uterine contraction. Also, for the bronchus, it causes bronchial constriction. So anytime you are releasing prostaglandin, you should watch out for where if the patient is asthmatic. Also watch out for the patient's breathing. Why? Because prostaglandin causes what? Bronchial spasms, but especially with cavapos. So also it increases intraocular pressure. So it increases intraocular pressure, but it's rare. Okay, so contraindications: don't give it to a patient with already uterine scar, maybe from a previous surgery, or a risk of rupture. Don't give it to an asthmatic patient, especially cavapos. Why? Because it's already causing bronchial constriction. Because anytime you give a prostaglandin analogs, it's always causing bronchial constriction, especially when you give cavapos. Glaucoma, because also prostaglandin is also used to relieve the eyes. Are you getting that? In case of glaucoma. So if you give the patient like that, you can cause more of what we call miosis. Are you getting that? When you cause miosis, that's another problem. Are you getting that? So you can damage the eyes. You get that? Okay, now you don't give it to a patient with cardiovascular, cerebrovascular, hepatic, and renal disease. Why? Because it will cause multi-system organ failure, and the patient could die if the patient already have a pre-existing heart condition, or a brain condition, or the patient sees, or the kidney function drops. So you don't give it to the patient like that, and there's always hypersensitivity. So if you give a patient NSAIDs, what does NSAIDs do? NSAIDs inhibit prostaglandin. Again, so if you give them together, the NSAIDs will not, the prostaglandin will not work. So don't give alongside NSAIDs. Also, don't give alongside other uterotonics too, especially with Ergot Alkaloids, Oxytocin. Don't give them together, because hey, it will just cause issues, causing laxity of the ligament that is holding the uterus. So there could be problem. Avoid combination with other beta blockers like propranolol. Yeah, if you give together with propranolol, what happens? It could cause excessive bronchial spasms, because propranolol act on beta 1, beta 2. So you give together propranolol, there's a problem. Also timolol and nadolol, but usually propranolol. So don't give alongside. So it's very, very important you know this. So we are done with oxytocic. So we have three. We have oxytocic, we have prostaglandin analogs, and we have ergot alkaloids. Don't forget oxytocic, ergot, and prostaglandin. PEO. Prostaglandin analogs, ergot alkaloids, and O, which is oxytocic. So the next one I'll be going into is what we call tocolytics. So we just ended with oxytocic. I don't want the drugs to be plenty. I don't want it to be tiring. So I'll be sharing oxytocic, and I'll be sharing tocolytic. You get it now? So it will be oxytocic tocolytic part 1, oxytocic tocolytic part 2. So we'll be sharing it into 2 so that you can watch it. Because I know if you watch it from beginning to now, and you might not continue. If I play all the videos, it will just take up to 1 minute. 1 hour. So I don't know whether you can stay. So we'll be sharing it into the next one. You get it now? So if you enter it, just click the next video on part 2 on oxytocic and tocolytic, and you continue. Bye bye.